You will all appreciate, I hope, that I'm showing you now a tinted picture of the man himself. And this, of course, is Etienne Louis Arthur Fallot. And we're going to be discussing today the evolution since these series of manuscripts that he produced in Marseille Médical, writing them in 1888. And as you can see from the title, he was taking benefit, his experience as a forensic pathologist. And he had noted that amongst the patients who came into his autopsy room, having died, unfortunately, with the feature of cyanosis, that there were particular features in the heart that grouped them together. He, of course, described these features using his native language, which is French. But if we translate the words he used, he noticed there was an interventricular communication. In his words, he noted the aorta was connected in both the ventricles. He observed that there was stenosis in the outflow tract of the lungs, but this was at subpulmonary level, and in all of the hearts, there was hypertrophy of the walls of the right ventricle. Now, of course, he did not call this Tetralogy of Fallot. The acronym, the name itself was gifted by Mort Abbott. But when we look at hearts, we can immediately recognize these features. So here we are looking base of the heart. We're looking in detail at the features that Fallot himself observed, and I've outlined there the right ventricular entrance to the interventricular communication. If you look carefully, you can see the attachments of the aortic valve in the right rather than the left ventricle, pointing out that there is biventricular communication of the aortic root. To the top of the screen, you can see the subpulmonary obstruction, which Fallot noticed, and there is obvious thickening of the ventricular walls. Now, this is what it looks like in a still image. But as you know, one of the features of our presentations to you now is that you can see these in the moving situation, as demonstrated to you by Diane. So Diane now is going to show you these features of Tetralogy of Fallot, and she's going to try to describe it using translation of the words that Fallot himself used.
This specimen has Tetralogy of Fallot, and you can appreciate that the aorta is anterior and rightward of its usual position, and in this case is quite dilated. This is the pulmonary trunk, which is of a much smaller caliber than the aorta, suggesting that we have pulmonary stenosis. The right ventricle is quite hypertrophied in this case. And if we look at some of the other phenotypic features we see with Tetralogy of Fallot, the first thing we'll look at is the interventricular communication. This defect extends to become an outlet defect because it extends between the limbs of the septomarginal trabeculation. So this is the septomarginal trabeculation with the cephalic limb extending up to join this anterior malaligned outlet septum. And here's the caudal limb, which gives rise to this medial papillary muscle that does not reach the inner heart curvature, so that this defect is perimembranous with fibrous continuity along the posterior inferior border between the tricuspid valve and the mitral valve. This is the ventriculoinfundibular fold, which is that muscle bundle that will separate the atrioventricular valve from the arterial valve. And in Tetralogy of Fallot, it also serves to support the aortic valvar leaflets, where they are in the roof of the right ventricle and overriding the interventricular septum. This area here is the right ventricular margin of the defect. If we look at some of the other phenotypic features, the anterior malalignment of the outlet septum causes this pulmonary stenosis. And the hypertrophy of these septoparietal trabeculations also put an extra squeeze on the outlet septum. These areas are safe for resection by the surgeon. And if this muscle bundle was removed, you can see how it would already expand that subpulmonary outflow tract. If we look at the left borders of the interventricular communication, you can see where the aorta is overriding the interventricular septum. And along the posterior inferior border, we have that fibrous continuity between the tricuspid and mitral valves along the posterior inferior border. And it's always important to remember that this area or space related to the interventricular communication is the left ventricular outflow tract.
So there you've seen the four features of the tetralogy. But throughout the ages since that time, morphologists such as ourselves have tried to focus on one of the features to tell us we're dealing with the entity. So what is the cardinal feature of tetralogy? Well, today we're going to try to link that to development. We're going to try to show you that the phenotypic feature is an abnormal location of the cushions, which in the normal situation divide the outflow tract into its systemic and pulmonary components. I can show you those cushions in the setting of tetralogy because this is the outflow tract, the subpulmonary infundibulum, removed from an autopsy specimen of tetralogy of Fallot. It has been corrected during surgery. So there you see the area that the surgeon had carved out in the infundibulum of the right ventricle. And at the bottom of the screen, you can see the leaflet of the aortic valve supported within the aortic root. So you can now appreciate what has become of those cushions in the setting of tetralogy. And you see that part persist as the outlet septum. These are the fused and muscularized proximal parts of the outflow cushions or ridges. The distal part is forming a freestanding infundibular sleeve. And this is another important feature that we're going to try to emphasize because the infundibular sleeve, as you see there, is separated by an area of extracavitary tissue between infundibulum of the right ventricle and the aortic root. So that is not what normally happens, because in the normal situation, those proximal outflow cushions become the freestanding subpulmonary infundibulum. And that tells us that in the normal heart, there is no muscular outlet septum, just as I showed you just a moment ago in the setting of tetralogy of Fallot. So what happens in the normal situation? Well, we can see exactly what happens now. So this is a section from a developing human heart. You see it's about 7 weeks of development. It's the stage we call Carnegie stage 20. CS stands for Carnegie stage. And it's very comparable to some of the features we're going to show you later. It parallels the oblique subcostal cut obtained by the echocardiographer. So there to the top, you see what will become the infundibulum of the right ventricle. But at this stage, the infundibulum is separated by these structures, and these are the muscularizing proximal cushions. So as you will see, I hope, they are separating at this early stage the infundibulum from what will become the aortic root. There is the aortic root, but at this stage, they have yet to fuse with the apical part of the muscular ventricular septum. So the cushions are closing a channel, which, as you see, is between the aortic root and the right ventricle. And we're going to be describing that channel as the aorto-right ventricular communication. And here you see it during development. Well, that channel is normally closed during development, and you see it here in mouse heart at the stage of closure. It's a very similar orientation. So there is the apical part of the right ventricle. There is the infundibulum, developing infundibulum of supporting the pulmonary trunk. And there to your left hand, you see the aortic root. But this is at the stage where that aorto-right ventricular communication has been closed by these two protuberances from the atrioventricular cushions, and we call those tubercles. What I'd like you to concentrate upon is what's happening to that section part of the proximal cushions. Because I hope you can see that the shell of the cushions has muscularized, and that will become the freestanding subpulmonary infundibulum. But the core of that cushion mass is going to become that extracavitary fibroadipose tissue, which separates freestanding subpulmonary infundibulum from the sinuses of the aortic root. And this is what happens after the interventricular communication, that aorto-right ventricular communication has closed. As there now you see the pulmonary root. This is another section from a human heart. You're looking at it in four-chamber fashion. And by closure of that aortopulmonary communication, the aortic root has now become connected to the ventricle. And there now you see the structures that have closed that communication. They are those tubercles, the atrioventricular cushions. I showed them to you just a moment ago. And they are now what will become the membranous part of the ventricular septum.
For this segment, I'm going to use 3 different hearts that have been dissected in 3 different ways. So here you'll see that I've removed the pulmonary valve and the pulmonary trunk. There's a remnant of one of the valvar sinuses there, just to show you how this subpulmonary muscular infundibulum lifts the pulmonary trunk up off of the right ventricular mass. So you can see that extensive sleeve of muscle there, adjacent to the anterior aorta. Here's the right coronary artery and the left coronary artery. When we look inside of the morphologically right ventricle, we can see this large trabeculation, which is the septomarginal trabeculation. From its inferior aspect branches the moderator band, but from the upper aspect, we have the limbs of the septomarginal trabeculation. The cephalic limb is here, and it rises up to become part of that subpulmonary muscular infundibulum, while the caudal limb extends back to reach the inner heart curvature or the ventriculoinfundibular fold. And that ventriculoinfundibular fold is the muscle that separates the atrioventricular valve from the arterial valve. Also, this heart shows nicely how the supraventricular crest is inserted between the limbs of the septomarginal trabeculation. And illustrating this prominent region in this heart will lead us to the other dissections that I'm going to show you the anatomy in a much more distinct fashion. So here, the free wall of the right atrium, right ventricle, and the pulmonary trunk have been removed, and you can see the right coronary artery coming from the aorta. This specimen has a very short subpulmonary infundibulum or muscular sleeve, unlike the last heart we saw, which it was much longer. And just like we are all different in our height, so are the different anatomies within the heart. So the length or height of the subpulmonary infundibulum may differ in specimens that we'll see. So to mark the septomarginal trabeculation, it is here. The cephalic limb extends up to become part of the subpulmonary muscular infundibulum. And here is the caudal limb that extends back to reach the inner heart curvature. This is the medial papillary muscle, which arises from that caudal limb of the septomarginal trabeculation. Here you can see the subpulmonary muscular infundibulum joining with the inner heart curvature, and the supraventricular crest is normally inserted between the limbs of the septomarginal trabeculation. This area here is the interleaflet triangle between the right and the non-coronary aortic valvar sinuses that I have removed just to demonstrate where the membranous septum is located and how closely related all of these structures are in the center of the heart. The last dissection that I have is a similar one to the last, but I've now removed the right coronary aortic valvar sinus. So you can see the bit of muscle that was supporting that sinus, which is normal. And here is our pulmonary valve. This specimen shows very nicely how this subpulmonary muscular infundibular sleeve lifts the pulmonary trunk up off of the right ventricular mass. And you can see that it is much longer than the last case we looked at. Also, you can see that it joins with the inner heart curvature and extends to reach the ventriculoinfundibular fold. This is the area where it has inserted between the limbs of the septomarginal trabeculation, with the cephalic limb here and the caudal limb here, again with the medial papillary muscle arising from that caudal limb. But the most important features that I want to show you is that there is a fibrofatty plane extending between that subpulmonary muscular infundibulum and the aortic root, and also a fibrofatty plane between the inner heart curvature, or that supraventricular crest, and the muscle that's supporting the right coronary aortic valvar sinus within the left ventricle. So that if the proximal outflow cushions insert normally between the limbs of the septomarginal trabeculation, there is no potential for an outlet septum in the normal heart. And I will mention here too that this dissection shows us the membranous septum, and you can see the interventricular component here and the atrioventricular component here.
So you've seen what happens during normal development. Those proximal cushions become the infundibular sleeve. You've also seen already, however, that if the aorto-right ventricular communication is not closed, then those cushions can persist as an outlet septum. And that's now what we're going to look at again in the setting of tetralogy of Fallot. But it is not simply malalignment of those outflow cushions that produces tetralogy, because there is one other important feature that gives us the phenotypic feature, tetralogy, and that is a squeeze between the malaligned outlet septum and the septoparietal trabeculations of the right ventricle. So here I can show you that situation. Again, I've taken a heart with tetralogy of Fallot, and I've sectioned it once more to parallel the oblique subcostal cut as produced by the echocardiographer. So there now you see we've sliced across the aortic root. And here now you see the proximal part of those cushions, which persist as the outlet septum. You can also see their more distal part, which is now forming the hypertrophied infundibular sleeve. And again, I'd like you to note that there is a space separating this infundibular sleeve from the sinuses of the aortic root. But when you now look more cranially, you can see there the hypertrophied abnormal septoparietal trabeculations. And that now shows us the phenotypic feature of tetralogy of Fallot, which is the squeeze between that malaligned outlet septum and those hypertrophied septoparietal trabeculations. Now, this is how we see it in the still image.
The free wall of the right atrium and right ventricle has been removed in this heart with tetralogy of Fallot, and the aortic root has been open. You can see that the aorta is anterior and rightward of its normal position and overrides the crest of the interventricular septum. The septomarginal trabeculation is here, and there is an outlet ventricular septal defect, which occurs or extends between the limbs of the septomarginal trabeculation. Here is the cephalic limb rising up to join the outlet septum, which is anteriorly malaligned. And here is the caudal limb, which is not reaching the inner heart curvature, rendering this ventricular septal defect perimembranous with fibrous continuity between the tricuspid and mitral valves along the posterior inferior border. In this specimen, there's also tricuspid to aortic valve fibrous continuity. And this little muscle bundle is the ventriculoinfundibular fold that separates the atrioventricular from the arterial valve. The important structures that we want to delineate here are this anteriorly malaligned outlet septum, which is quite prominent in this specimen, and the extension of the subpulmonary muscular infundibulum that's lifting the pulmonary valve, which is here, up off of the right ventricular mass. The outflow tract is quite elongated and quite stenotic in this case, secondary to this prominent outlet septum and to hypertrophy of the septoparietal trabeculations, which put an extra squeeze on the outflow tract in addition to the septal malalignment. So the septal malalignment, along with the hypertrophy of the septoparietal trabeculations, is the phenotypic feature of tetralogy of Fallot. You'll also note that there was an aorta to pulmonary shunt in this case.
I'm now going to introduce you to another key player in our understanding of tetralogy of Fallot, because this young man is Neeraj Nirmal Pandey. Neeraj now has been working with me quite some time by the internet to share my anatomical experience and that of Diane with his experience as a professor of cardiac radiology at the All India Institute of Medical Sciences in New Delhi. What I'm now going to share with you is the wonderful image that Neeraj has prepared showing us his phenotypic features using computed tomography. So you saw my section paralleling the subcostal oblique cut. This is Neeraj's exquisite picture showing the same cut in a computed tomographic data set from a patient with tetralogy. And there again you see the malaligned outlet septum. And you see the hypertrophied infundibular sleeve. And once more you can recognize that infundibular sleeve is separating freestanding, narrowed infundibulum from the sinuses of the aortic root. But what you can see particularly nicely now is the abnormal septoparietal trabeculations, and this cut of the echocardiogram of the computed tomographic data sets shows you exquisitely the phenotypic feature of tetralogy of Fallot. And it is now the knowledge of normal development that lets us understand the phenotypic variables that we find in tetralogy, because not all the cases are the same. We've shown you now how you can recognize the phenotype in the autopsy specimens. We've shown you how beautifully that can be seen using computed tomography. But now we can look to see the variation between these features. And we're going to start off with the extent of biventricular connection of the aortic root. And then we're going to look at the phenotypic variability we can find in the borders of the interventricular communication. And we're going to try to clarify exactly what we mean by the interventricular communication. But let's start with looking at the biventricular connection of the aortic root. Why does the aortic root have a biventricular connection? And it has this biventricular connection because initially it's supported exclusively above the cavity of the developing right ventricle. And then the channel that persists between the ventricles, which subsequent to the expansion of the atrioventricular canal is the secondary interventricular communication, it is the outflow tract for the left ventricle. And I've shown you this before. I make no apologies for showing it to you again, because it's the early stage of development in the mouse heart after there has been expansion of the atrioventricular canal. So here you're looking at the right ventricle. And I hope you can now appreciate that the aortic root is supported exclusively by the right ventricle. But you can also see the channel between the ventricles. That is the secondary interventricular communication. The part primary communication now encircles the tricuspid orifice, which you can see at the back of the screen. But now we can create a triangle of space beneath the aortic root. Those of you who saw our last session of 2023 will know we emphasize this triangle of space. And you see that the secondary interventricular communication is now the aorto-left ventricular communication. But now I'd like to concentrate your attention on the other entrance to the aortic root, because that is the aorto-right ventricular communication. And it is that space that is closed to put the aortic root back into the right ventricle. And we've shown you this before. We show this again, because you see there the muscular ventricular septum, there the developing aortic root, but now you see the structures that have placed the aortic root into the left ventricle. And they are, of course, the fused proximal cushions, which we've already discussed. And now, when we look at the triangle of space once more, we can see once again the secondary communication as the aorto-left ventricular communication. But what we now see is that the fusion of the cushions has built the shelf so as to put the aortic root into the left ventricle. But behind that shelf, there is the persisting aorto-right ventricular communication, which you have also seen. So this is a more dorsal cut from that same data set. And now when we look at the triangle of space once more, we see again the secondary communication, which is the aorto-left ventricular communication, but we see that narrow space that will be closed by the tubercles. And this is the aorto-right ventricular communication. And in the setting of tetralogy fellow, that is the space that is going to be closed to put the aortic root back into the left ventricle. And I can show you a still image of that. This is one of Diane's specimens. She's going to show you this very shortly in a video. But let me emphasize again what you are going to see. This is a 4-chamber cut incorporating the aortic root. And there once more is our triangle of space subtended beneath the aortic root. And what we have to appreciate now is the difference between the aorto-right ventricular communication, which will be closed, put the aortic root back into the left ventricle, and the aorto-left ventricular communication, which is the persisting secondary interventricular communication. So here you see it in a still image. Let's now look at it in one of Diane's videos.
This is the same specimen that Professor Anderson just showed in his PowerPoint, and you can see that it's cut in a 4-chamber plane. So that here's the tip of the right atrium, tricuspid valve, and right ventricle. This is left atrium with mitral valve and left ventricle. If I put my probe along the muscular interventricular septum, you can see that the aorta is overriding the septum and is slightly more committed to the left ventricle than it is to the right. Also, this triangle of space is easily appreciated so that this area is the right ventricular entrance to that interventricular channel. This is the left ventricular entrance to that interventricular channel. So that this triangle of space marks that interventricular channel, and it's important to remember that this area, or the left ventricular entrance to that interventricular channel, is the left ventricular outflow tract. It's only common sense that the surgeon would place their patch in this area along the right ventricular entrance to put the aorta back into direct communication with the left ventricle and the left ventricular outflow tract.
You see, of course, also this space when you're looking at echocardiograms. And this is a parasternal image prepared also for me by one of my colleagues at the All Institute. This is Sauram Gupta, who is now a professor at the All India Institute. This is one of Saurabh's echoes. Again, you see the triangle of interventricular space with the aorta left ventricular, the aorta right ventricular communications. But in this example, the aortic root is shared between the ventricles. In other instances, however, the aortic root can be exclusively connected within the right ventricle. We can see the same thing in one of Neeraj's echoes, one of Neeraj's computed tomographic data sets. Again, this is the situation you see in the balanced situation. Aorta left ventricular communication is the left ventricular outlet to the root. It is the aorta right ventricular communication that will be closed to put the aortic root back into the left ventricle. So this is the arrangement when there is a balanced connection.
Here we're comparing two specimens that have different ventriculo-arterial connections. Both are cut in a four-chamber or near four-chamber plane. The smaller specimen has tetralogy of Fallot with concordant ventriculo-arterial connections, with the aorta a slight bit more committed to the left ventricle than it is to the right. The larger specimen has a double outlet right ventricle. It's important to remember that it is always the aorta left ventricular communication that is the outlet for the left ventricle. So here is the left ventricular outlet or the left ventricular to aorta communication. And on the Hartwood tetralogy of Fallot, this area is the left ventricular outlet or the left ventricle to aorta communication. It's important also to remember that the aorta to right ventricular communication is the space closed by the surgeon, irrespective of the degree of override. So that if we look at where the surgeon would put their patch in the Hartwood tetralogy of Fallot, it would be right along this plane or the aorta to right ventricular communication. And in the Hartwood double outlet right ventricle, it would be in this plane to put the aorta back into communication with the left ventricle.
And I can now emphasize the situation Diane showed you just a moment ago by showing you yet another of Neeraj's exquisite computed tomographic images. Because here you see the aortic root, and it is supported more or less exclusively by the right ventricle. But let's return once more to our triangle of space. It is still the aorta left ventricular communication, which is the outflow tract, left ventricle. And the surgeon wished to correct this patient, the surgeon would still have to close the aorta right ventricular communication. Irrespective of the degree of aortic override, it is the aorta right ventricular communication which is closed. And this is a virtual dissection of that self-same data set prepared by Neeraj. And now Neeraj has made the cut in such a way that you can see malaligned outlet septum, normal septoparietal trabeculations, and the squeeze that tells us we are dealing with tetralogy of Fallot. But moreover, he can now show you the extensive aorta right ventricular communication that is the entrance to the aortic root. And so, if we return to our triangle of space, that triangle of space is simply part of the channel between the ventricles. And arguably, any plane within the space is a ventricular septal defect. It is the borders of the space that are of clinical significance. And when we look at triangular space again, it is the left ventricular margin, which is the outflow tract of the ventricle. It's obvious, therefore, if that is narrowed, we will have subpulmonary obstruction. But this is the point we want to emphasize to you today. Irrespective of the extent of aortic override, it is that right ventricular margin that we closed by the surgeon so as to restore septal integrity. And so it is these margins that are clinically significant, particularly the margins of that aorto-right ventricular communication. So here is how I look at that aorto-right ventricular communication. And it is how Diane has demonstrated it to you today. There you see the tricuspid valve, right ventricle, the subpulmonary infundibulum. So the area that we should be concerned about when we ask the surgeon to correct any patient with tetralogy of Fallot is this right ventricular entrance to the aortic root. And you can see that in this particular instance, part of that space is made by tricuspid to mitral continuity. And that means that this area is perimembranous. There is then part that is supported by the inner heart curvature, which we call the ventriculo-infundibular fold. The cranial margin is the aortic side of the outlet septum, and that has a parietal extension, and it has a septal extension. And the septal attachment is positioned anterocephalad relative to the limbs of the septomarginal trabeculation that reinforce the crest of the muscular ventricular septum. Nowadays, we can show the margins with exquisite accuracy using computed tomography. So I've returned to that exquisite image prepared for me by Neeraj, and you can again see the similarity I showed you in the autopsy room, and which now Neeraj can show you using virtual dissections of computed tomographic data sets. So there you're seeing the cavity of the left ventricle. There you see the squeeze that tells us we're dealing with tetralogy of Fallot. And now Neeraj is showing you the margins of the space that will be closed by the surgeon so as to put the aortic root back into the left ventricle. And for me, irrespective of the degree of aortic override, I would call that the ventricular septal defect. And in this instance, you see that the defect opens right ventricle between the limbs of the septomarginal trabeculation. They are reinforcing the crest, the muscular ventricular septum. Cranially, the outlet septum. And then as we come round the margins, which is to be closed by the surgeon, we see the ventriculo-infundibular fold. And then posterior-inferiorly, we have the area in this particular specimen tells us we are dealing with a defect that is perimembranous. But not all of those defects are the same. They are all malalignment outlet defects, but they vary according to their margins. And that phenotypic variability has clinical significance, and it requires us to recognize those embryonic building blocks of the outflow-trans. So Diane now, in a series of specimens, is going to show you that variability that we find in this aorto right ventricular communication, right ventricular entrance to the triangle of space subtended beneath the aortic root that the surgeon will have to close so as to put the aortic root back into the left.
If we revisit the specimen that we saw in the very first video, we can look at the margins of the interventricular communication. The inferior most margin shows us that this is an outlet defect because it extends between the limbs of the septomarginal trabeculation. This caudal limb, which gives rise to the medial papillary muscle, does not reach the inner heart curvature, so that this posterior inferior border is fibrous, with fibrous continuity between the tricuspid valve and the mitral valve along that posterior inferior border. The ventriculo-infundibular fold is that muscle bundle which supports the aortic valve in the roof of the right ventricle, where the aorta overrides the interventricular septum, and the anterior superior most margin is formed by the malaligned outlet septum. This is another specimen with tetralogy of Fallot. Here you can see the subpulmonary stenosis and the right ventricular hypertrophy. And if we look at the margins of the interventricular communication compared to the last specimen that had a perimembranous ventricular septal defect, we can see the borders of this defect still extend between the limbs of the septomarginal trabeculation, making it an outlet ventricular septal defect. The caudal limb of the septomarginal trabeculation now reaches the inner heart curvature or the ventriculoinfundibular fold, and this defect has a muscular posterior inferior border. The conduction tissue will then be protected by this muscular border. Looking at the anterior most border or the ventriculoinfundibular fold, you can see that it again still supports the aortic valve where it extends or overrides the interventricular septum, and the outlet septum forms this anterior superior border. So this defect has a muscular posterior inferior rim which will be protective of the conduction tissues. This tiny fetal heart is all I have available at the moment to show you the anatomy of a juxta-arterial defect. This is the short axis of the specimen where we can see the aortic valve that is anterior and rightward of this pulmonary trunk, which is just here. This is the left atrial appendage, and here's the right atrial appendage. When we look at the specimen inside, the aortic valve is supported by a complete muscular infundibulum, and you can see that the interventricular communication is in the subaortic region, and it does extend to become perimembranous with fibrous continuity between the tricuspid and mitral valves along that posterior inferior border. This defect is juxta-arterial because there is fibrous continuity between the aortic valve and the pulmonary valve, which is where I have my probe at the moment. And this is secondary to anterior deviation of a fibrous outlet septum, so that there is pulmonary stenosis and the arterial valves are in fibrous continuity with one another, with that fibrous raphe or outlet septum interposing between the two arterial valves.
So, Diane has now shown you that in the autopsy room, but Neeraj can show you that variability with just as much accuracy. So here is one of his cuts, again replicating the parasternal subcostal echocardiographic cut. Again, you see the squeeze that tells us we're dealing with tetralogy of Fallot. There is the malaligned outlet septum. But now, when we look posterior-inferiorly, we see the ventricular infundibular fold. And as Diane showed you, in this particular instance, where the defect opens between the limbs of the septomarginal trabeculation, the fold has fused with the caudal limb, septomarginal trabeculation, so that we have a muscular outlet defect. And there it is. The margins of the aorta right ventricular communication in this instance are exclusively muscular. But here is another one. There is the squeeze again, the hypertrophied septoparietal trabeculations, but this time the squeeze is between the septoparietal trabeculations and a fibrous outlet septum. There, it still opens between the limbs of the septomarginal trabeculation. There is a muscular posterior inferior rim, but this time the defect is juxta-arterial. The key feature, however, its posterior inferior margin is once again myocardial. And that is key because when it is present, that muscular posterior inferior rim protects the atrioventricular conduction axis. So now Diane will show you the influence of that rim of myocardium guarding the atrioventricular conduction axis.
We've already seen this specimen, and we want to stress at this point the posterior inferior border of the defects that we see in tetralogy of Fallot. Of course, we know there are outlet defects extending between the limbs of the septomarginal trabeculation, and the ventriculo-infundibular fold supports the aortic valve as it overrides the interventricular septum or within the roof of the right ventricle. And then here we have our anteriorly deviated outlet septum. In this specimen, the caudal limb of the septomarginal trabeculation does not reach the inner heart curvature, rendering this defect perimembranous, so that along the posterior inferior border, we have fibrous continuity between the tricuspid valve and the mitral valve. The conduction tissue is in peril in this type of defect because it will run right along this muscle just at that, or just deep to that fibrous continuity between the tricuspid and mitral valves, with the right bundle branch emerging inferior to or relative to the medial papillary muscle and extending along the septomarginal trabeculation. When we look at the left side of the defect, you can see nicely here that the posterior inferior border is fibrous, and there is the mitral valve here and the tricuspid valve within the right ventricle. So they are in fibrous continuity. And this specimen actually has a remnant of the membranous septum, and this membranous tissue would be safe for the sutures, or for the surgeon to place sutures in that membranous remnant. The left bundle branch will emerge in this area and track along the crest of the ventricular septum before it trifasciculates over the septum. So again, this posterior inferior fibrous border or perimembranous ventricular septal defect has surgical implications relative to the conduction tissue and where the surgeon will place their sutures. If we look at a similar specimen with tetralogy of Fallot, again, looking at the borders of the defect, it too is an outlet ventricular septal defect. Here is that ventriculo-infundibular fold that supports the aortic valve within the roof of the right ventricle, and here is our anteriorly deviated outlet septum. If we look at the posterior inferior border of this specimen, the caudal limb of the septomarginal trabeculation reaches the inner heart curvature, so that the posterior inferior border is muscular. In this specimen, the conduction tissue will arise at the apex of the triangle of Koch and run deep to that posterior inferior muscular bar. It again will emerge relative to the medial papillary muscle, which is here, arising from that caudal limb and extend along the septomarginal trabeculation. Looking at the left side of this defect, this muscle bar extends up between the tricuspid valve and the mitral valve, and as well between the tricuspid valve and the aortic valve. So there is that muscle bundle here and extends along the entire posterior inferior border, so that the membranous septum will remain intact in this specimen, with the left bundle branch emerging relative to the central fibrous body and running along the posterior inferior border deep to this muscle bar before it trifasciculates over the left ventricular septum.
There are, of course, other features that are of major clinical significance. There can be a second muscular inlet defect present. In a small proportion of cases, tetralogy can coexist with an atrioventricular septal defect. There can very rarely be straddling and overriding of the tricuspid valve. In a proportion of cases, there can be pulmonary atresia rather than pulmonary stenosis. And of course, major clinical significance is the presence of coronary arterial anomalies. And all of these features now can be demonstrated to you by yourselves in the clinical setting using echocardiography, and increasingly, as we have seen, shown to us by Neeraj, using computed tomographic analysis. But what we have tried to emphasize to you today is the phenotypic feature of tetralogy, is the anterocephalad malalignment and deviation of the muscular outlet septum or its fibrous remnants, but combined with an abnormal location and usual hypertrophy of those septoparietal trabeculations. And it is the two together that provide the squeeze, giving us tetralogy of Fallot. But the major take-home message is what I also hope we've shown you: irrespective of the degree of aortic override, the surgeon closes the aorto-right ventricular communication. Now, we can argue as to what we call the ventricular septal defect, and you are all well aware that currently, in the setting of double outlet right ventricle, which we will discuss in our next session, it is the aorto-left ventricular communication that is conventionally described as the ventricular septal defect. To me, that does not make a lot of sense, because what I hope we have shown you is, irrespective of the degree of aortic override, it is the aorto-right ventricular communication that should be closed and must be closed by the surgeon to restore septal integrity. And for that reason, we believe it is that margin that is strictly the ventricular septal defect, but we can resolve the controversy simply by distinguishing between the aorto-right ventricular communication and the aorto-left ventricular communication. So that is our take-home message, which we will reinforce in our next session when we discuss the variability to be found in the setting of double outlet right ventricle. Well, thank you very much, Diane, again for spectacular video demonstrations. We have Justin Tretter with us today. I'm pleased to say Justin has joined us for, I hope he's going to be able to join us for our sessions as we progress through 2024. Justin is equally proficient at both echocardiography and computed tomography. So Justin, perhaps you'd like to make a few comments on what we've shown you today, trying to match what you can achieve in the clinical setting with what we see in the autopsy room.
Yes. So we've our group has wrestled with these concepts, and I think for the clinician, it always comes down to what is clinically relevant, what is clinically and surgically relevant. And as we talk today, and as we'll talk in the next session on double outlet right ventricle, congenital heart disease is often much more complex than we try to make it. And these are examples where understanding the three-dimensional, when we're talking about the beating heart, the four-dimensional margins of what truly is the ventricular septal defect, and versus understanding when we think about the hemodynamics and thinking about that RV to aorta versus LV to aorta pathway. These are very clinically and surgically relevant concepts. And it becomes very challenging trying to define that with two-dimensional echo or any kind of two-dimensional imaging. And that's where what you're showing using three-dimensional data sets. Here we're focusing on cardiac CT, but we can do the same with cardiac MRI, maybe not quite the spatial resolution. We can also do a great job with three-dimensional echo, especially with some of the advanced technologies over the past year with new pediatric TEE 3D echo probes.
You and I, Justin, have previously discussed the efficiency that you can do with computed tomography, and I asked Neeraj if he could show us both the phenotypic feature of tetralogy and the aorto-right ventricular communication in the same cut, and as you saw, he has achieved that. It is very difficult, however, is it not, to obtain that echocardiographically, even with a three-dimensional data set?
Well, with any three-dimensional imaging, it's only as good as your two-dimensional imaging, and that's very true for echo. The saying is garbage in, garbage out. So if you have from transthoracic echo, if you have poor transthoracic acoustic windows with two-dimensional imaging, you're not going to stand a chance trying to do three-dimensional imaging. There's different things that you can do to try to improve that in a younger child, to sedate a child. But I think what I'm excited about is the new pediatric 3D TE probe. GE has a new probe that came out within the last year, the 9VT probe, and we've been using this in our operating room. And often you do have much better windows with transesophageal echo and can achieve very nice three-dimensional data sets. The advantage, though, with the CT is in all directions. You have, when we say consistent spatial resolution, we're saying that within that three-dimensional volume that you have all directions, axial, sagittal, coronal, you have consistent high spatial resolution. Even with the best echo imaging in certain planes, you may lose that spatial resolution. So that can be the challenge sometimes. And when you're trying to do that in the operating room, it obviously is a more, I don't want to say rush scenario, but you have limited time with that preoperative assessment, and to do some of that post-processing that you're talking about to cut into the different planes can take time. So those are some of the limitations with trying to do that with echo. With CT, you get the data set, high consistent spatial resolution. With some of the new technology, with not only the dual source scanners, but now the photon counting scanners, we can really limit the radiation exposure, and it can be done in a much more relaxed setting where you're post-processing, making these 3D reconstructions. You have time to converse between the surgeons and cardiologists to look at the imaging. So I do think that there should be a low threshold in more complex cases to get CT in these various lesions.
I was fortunate enough on Wednesday, in fact, Neeraj is in London at the moment for a radiology meeting, and I was able to host him for lunch on Wednesday. And he was telling me, in fact, that at AIMS in New Delhi, they're about to get the new photon CT machine that you mentioned. But he, to me, I mean, he tells me also that at AIMS now, they're doing CT in all of their patients with tetralogy. Are you doing the same at the Cleveland Clinic?
Not in tetralogy of Fallot. In double outlet right ventricle, I would say, unless it is the most basic subaortic defect, we will have a low threshold to get cardiac CT, and we're doing a lot of 3D echo, trying with transthoracic when the windows are there, and then we definitely are doing it in the operating room with the preoperative transesophageal echo.
And with 3D echo now, you're confident you can always diagnose whether the defect is perimembranous, whether it has that muscular posterior inferior rim. You can work out the adjacency of the conduction axis to the margins of the defect.
Well, I think you're hitting on the point of, in my, what I would emphasize is multimodality imaging, that each of these have their advantages and disadvantages. For defining the margins of the defect, I still think two-dimensional echo is more than sufficient. If we understand the central fibrous body, we understand the building blocks of the right ventricle, then and that comes down to the importance of these sessions, the importance, and I would love to hear Diane's input, because she's starting to explore herself as an anatomist now, getting into my world of imaging. She's doing a lot with surgical theater and using CT data sets too. But you have to build this anatomical understanding to know what the anatomy is, to then be able to accurately assess that with clinical imaging. And once you understand what comprises the central fibrous body and the normal heart, the building blocks of the right ventricle, you can then easily use two-dimensional echo to distinguish the borders of the ventricular defect, to define the three-dimensional margins of the defect and distinguish between what we're talking about, the LV to aortic or RV to aortic pathways. That becomes challenging to understand the three-dimensional margins geometry of the defect, and that's where the three-dimensional imaging then becomes important. Between echo and CT, echo certainly can do a better job with understanding the dynamic functional nature of the ventricles and the heart. It can do a better job of teasing out some of the details of the valve. That's where we rely a lot on echo to really look at the details of valves. So in this specific lesion, understanding when you're talking about straddling and overriding of valves or any kind of abnormality in valves. But CT is certainly going to be very useful if it is primarily a question of the three-dimensional spatial relationship related to these different communications.
I hear what you say about the value of two-dimensional cross-sectional echocardiography, but it continues to be a mystery to me that we've been talking about these differences now for 40 years or on, but you will know full well that amongst echocardiographers, it's not frequent to find emphasis placed on these different borders of the defect in the setting of tetralogy of Fallot. I mean, I'm not asking you to explain that, but why should it be that it's taken so long for this to emerge?
Well, I think I can explain it. I think it's simple. You don't know what you don't know, correct? And that goes again to the importance of these sessions and recognizing that while historically, I think our field has tried to oversimplify various lesions. As we have the ability with advanced clinical imaging to take the knowledge that you and Diane have as anatomists and really bring that into the clinical setting, we need to start to improve our foundational understanding of the anatomy to personalize surgical and interventional planning. And I would just add in there, part of that multimodality imaging evaluation is certainly the intraoperative surgical inspection. And that's where speaking the same language, having everybody on the team having that unified understanding of the anatomy and that consensus terminology becomes very important, because even with the best imaging, there's things that can be missed even with the best imaging that needs to be inspected for in the operating room.
I mean, we should bring in Diane at this stage because, as you say, once more, she has demonstrated to us the morphology so exquisitely with her specimens. And I didn't press her this time. I left her to do her own thing, and she more than it surpassed my expectations. So, Diane, would you have any comments on what Justin has been saying, what I've been saying, and you're now taking this forward?
Yeah, I agree with everything Justin said as far as imaging goes. And here, as he said, I've been getting a little bit more experience looking at 3D images, which I have not done until the past 2 or 3 years, as I've been working here at Johns Hopkins All Children's. And Dr. Q and our interventionalists make use of this surgical theater three-dimensional imaging quite often. If they have any question, especially Dr. Q, about the borders of a defect, they will get a CT on the patient. As Justin said, they don't get it on every patient, but if there's a question, they do want to look at it in surgical theater. And Dr. Q is very keen on actually coming and looking at specimens when he has a question in his mind about variations in the gross specimens. So he will often call me to actually look at the specimens in his hand and then compare things with surgical theater and what we're seeing. And it's been interesting for me being all these years having the heart in my hand. And as you know, Bob, we can push things around a bit to make the septum move a little bit. Or it's not actually all the time as we see it in life. So this has been interesting for me to learn what we actually see in the living patient, and also to help the guy who's training me, Michael Miller, on surgical theater, to help him with his anatomic knowledge too. So it's been a nice give and take for me to learn more of this clinical data than just the straight anatomical data with the specimens. So it's been a lot of fun and good to share these things.
How easy is it to make video presentations using surgical theatre?
Michael does it quite often. He's done it a few times for Dr. Q for presentations, for PowerPoints. And I know Justin has done a couple of videos for me, not using surgical theater, but using his CT data sets. So he can do it very easily, but that's above my pay grade right now.
I know, as you saw for today's presentation, I was using very much the still images that Neeraj had prepared for me. But I guess, in a way, we should be moving perhaps to be making CT moving videos. Justin, is that feasible?
Are you referring to looking at the dynamic part or dissections cutting through the static?
I mean, in a way, the virtual dissection showing how you move into the heart. I mean, I've seen Tony Levarchek used to do those and drive you into the heart so you can.
Right, and that's what, and we have done that in the prior sessions here with some of the videos that I've provided have cut into different planes. And yeah, that's simple enough. If you're talking about looking at the dynamic heart, that depends on the CT. Rarely in these neonates with double outlet right ventricle tetralogy of flow would you get a 4D CT data set, but you've seen some of the work we do with the valve work. We get that often with some of our valve planning cases. But the issue that you'll have there then is while you can get very nice imaging in a quiescent period of the heart in mid diastole, or sometimes when the heart rate is faster, you can actually get it in systole. If you try to get a four-dimensional data set throughout that heartbeat, you'll have varying image quality.
Right, so we don't seem to have any questions from our audience. So I'm indebted to you, Justin, for being with us and for contributing so much to the discussion. Norman has not been with us this week, or at least I haven't seen him appear, so I guess he might be sleeping in California. We know that Adrian is in Romania, but we hope that Adrian will be joining us next time. So on February 16th, we will have our next session when we will move on and we will get to grips with that controversial issue. Is it still the ventricular septal defect that is closed by the surgeon in the setting of tetralogy of double outlet right ventricle? But I hope that the example we've used for tetralogy of fellow will show the direction of our travel. So Diane, thank you again for those splendid dissections. Justin, thank you for being with us. And we hope everybody will join us again for our February session. So thank you all.
Thanks. Have a good weekend.